So, Devita chapter 43 Cancers of the kidney. Kidney is kidney encompass a heterogeneous group of cancer derived from the renal epithelial cells, which is neither common enough to cause a large percentage of cancer-related death, nor uncommon enough to be considered orphan malignancy. In that context, the progress made in uncovering the genetic basis of renal cell carcinoma, its molecular pathways, and the approval of novel therapies to perturb those pathways over last decade is indeed remarkable. Over a relatively short time, the management options for localized kidney cancer have evolved from near universal acceptance to open radical nephrectomy to the routine use of minimal invasive partial nephrectomy and thermal ablation, active surveillance. Concurrently, metastatic RCC has progressed from marginally treatable with a low incidence of spontaneous and or immune induced durable progression to overall response rate, complete response, plaster response, stable response of more than 50%, and near a doubling of cancer specific survival. In the note, so far future, it is anticipated that kidney cancer will soon become chronic disorder as we better understand its biological heterogeneity and complex interrelationship with systemic anti-angiogenic and novel immunotherapy and combinations. So now we will see the epidemiology and demographic and risk factor. Kidney cancer accounts for approximately 2% of the malignancies worldwide, with about 4,25,000 cases diagnosed per year and 1,37,000 deaths. The incidence of kidney cancer is highest in Czech Republic. RCC is diagnosed 1/69 in men and 1/116 in women, so almost double. Kidney cancer remains predominant tumor of elderly, median age 65, rising in younger individuals, either increasing use of non-invasive imaging in young patients. And the most commonly cited risk factor for development of RCC include smoking, obesity, and hypertension. The data regarding smoking as a risk factor for RCC appears strong, and in a meta-analysis evaluated 19 case control studies and 5 studies, Hunt et al. Found 38% increased risk of current and former smoker, 38% increased risk, and noting not only a dose risk relationship but also an abatement of risk with smoking cessation after 10 years. And the relationship between obesity and RCC is less well understood, and although epidemiology seems to point a causal association in a quantitative review of a literature between 1966 and 1998, Renehan et al. Evaluated a risk of 1.07, relative risk of 1.07 per increase in unit BMI, and concluded that nearly a third of RCC cases may be attributed to obesity. Then there is paradoxical relationship between obesity and RCC has been noted, and with improved survival outcomes observed in those with higher BMI. Recent tumor expression analysis has noted decreased expression of FASN, an enzyme needed for fatty acid synthesis. So there is one enzyme, fatty acid synthesis something and that enzyme is needed for fatty acid synthesis, and in renal tumor from obese patient this enzyme has decreased. The relationship between hypertension and RCC is based largely upon the retrospective and population based epidemiological data. Noted hypertensive patient exhibit pooled odds ratio 1.75 of having RCC, and while there may be relationship between severity and duration of hypertension, given the limits of the data, if such an association exists, it is difficult to ascertain. Finally, several lifestyle and dietary, pharmacological, occupational, environmental factors have been linked to an increased risk of RCC. While screening for kidney, another potentially lethal disease, is enticing, risk-benefit analysis argues against it given the low overall surveillance of RCC in general population. One study in which around 2 lakh adults were screened for abdominal malignancy with ultrasound found only 192 cases of screen detected RCC, and as a result, screening has therefore become proposed in only a target population, including individuals with a familial RCC syndrome such as VHL, von Hippel-Lindau disease, and those with hemodialysis and who are known to be more likely to be diagnosed with RCC in families who carry known mutation in the gene responsible for the hereditary RCC, like hereditary papillary RCC, hereditary leiomyomatous RCC, Birt-Hogg-Dopf syndrome, tuberous sclerosis. The renal ultrasound has been proposed as an inexpensive, low-risk, judicious means of targeted screening, and the initial timing, frequency, effectiveness of screening in this at-risk population are not yet established, and a direct causal link between the hemodialysis and RCC that remains to be elucidated. So pathology of RCC, pathological classification assigns the diagnosis and prognosis, and most patients class 16 subtypes of by WHO system. So these are different subtypes. We are not going into detail at present. The major histological type is clear cell papillary chromosome and collecting duct. Four major accounts for around 90 to 95% of the renal carcinoma. Less common subtypes, unclassified categories of RCC. Less common subtypes like histiocytic RCC, mixed clear cell, papillary RCC, cystic disease associated RCC, hereditary leiomyomatous renal carcinoma syndrome associated RCC, succinate dehydrogenase deficient RCC, and the relatively rapid movement in RCC towards molecular classification follows advances in our molecular understanding of these variants and may soon supplant this simple morphological classification system. Other pathologically relevant variables in RCC include nuclear grade, sarcomatoid, rhabdoid differentiation, tumor necrosis, vascular invasion. Furman grading system was the most commonly used system for clear cell RCC, and its prognostic value in non-clear cell RCC remains unknown. As a result, 4-tier WHO SIUP grading system was introduced for clear cell and papillary RCC, but not as endorsed for the chromophobe RCC. And sarcomatoid differentiation that exists in 5% of the RCC and can be seen in any subtype. And it carries a poor prognosis. Sarcomatoid subtypes carries poor prognosis. Present and extent of micro and macro necrosis has been evaluated as a prognosis in clear cell RCC, whereas the correlation between extent of micro and macro vascular invasion prognosis remain ill-defined. There are differential diagnosis for RCC. Most patients with RCC present as an incidental radiographically detected renal mass, while symptoms include microscopic or gross hematuria, flank pain, gastrointestinal disturbance, pain, bleeding, systemic disturbances related to metastasis may lead to diagnosis, and the use of routine cross-sectional imaging may lead to more common scenario of an incidentally detected renal mass. While the suspicious for RCC may be high in cases of this, RCC is a pathological tissue diagnosis, not clinical one. Proper radiographic evaluation of renal mass require pre and post contrast CT, MRI to assess the enhancement, and duplex ultrasound renal mass biopsy, non-contrast diffusion weighted MRI, and drug conjugate mapping may be useful adjunctive test in various clinical settings. PET exhibit low sensitivity and therefore not recommended for evaluation of RCC. And technetium system PET scan is a test clinically used for detection of the parathyroid, but was recently introduced as a potential tool for detecting mitochondrial rich tumor like chromophobe RCC and oncocytoma, or chromophobe RCC and oncocytoma, with a sensitivity specificity 83-95% respectively. And immunopet with G250 using an iodine labeled antibody against carbonic anhydrase 9, which is known to be overexpressed in clear cell RCC, exhibit a 90% sensitivity and specificity for RCC. And differential diagnosis of the renal tumor is broad and include long list of benign malignant inflammatory condition, clinical radiological features, then can assist the astute clinician in narrowing down the diagnosis of the renal mass, particularly for the benign and inflammatory condition. Cystic lesion, for example, frequently benign, and fat containing solid lesions, they are most commonly found angiomyolipoma, which is also benign. About 20% of the enhancing renal mass and 15% of the surgically removed masses are non-malignant. Okay, around 15% surgically removed mass, they are non-malignant, and 20% enhancing mass, they are non-malignant. Most commonly diagnosed benign oncocytoma, fat poor angiomyolipoma, and young to middle-aged women particularly are more likely to have benign pathology, as high as 40% in some. And tumor size is the most important determinant of pathology, and biology aggressive with larger tumors more likely to be high grade, locally invasive, and adverse subtype. Incorporation of the readily available radiographic features may allow the physicians to provide individualized risk of cancer, but a certain diagnosis remains pathologically confirmation, and the most accurate nomogram currently available give estimate of preoperative prediction of tumor histology with an area under curve of 0.76 with high grade malignancy with an area under curve 0.73. So percutaneous renal mass sampling that is being performed increase regularly according to 2020 AUA guideline. There is a strong rationale for biopsy in finding will change management, and when there is a reason to suspect lymphoma or leukemia or abscess to guide the systemic therapy for metastatic disease. For systemic therapy for metastatic, even for clinically localized renal tumors, conventional renal mass biopsy can provide definitive histological diagnosis 80 to 90%. However, the ability to grade RCC remains substandard, with concordance rates ranging from 60 to 70%. As data regarding the safety and accuracy of the renal mass biopsy continues to mature, some have advocated for near universal use of renal mass biopsy prior to treatment. The use of renal mass biopsy should be considered judiciously, as it will not always impact management and in some scenario may add more uncertainty. Kutikov et al. Have proposed a risk stratification algorithm for the appropriate selection of patient for renal biopsy bars. So this is the algorithm of Kutikov. If there is a renal mass, we are suspecting lymphoma, abscess or metastasis, then we can go for willing to accept biopsy, then go for biopsy. If no, then keep for active surveillance. Then if patient is a candidate for active surveillance, keep for active surveillance. If there is a clinical benefit of histological risk assessment, yes, then go for biopsy. And if ablation is planned, then also go for biopsy. And if the patient treatment team willing to observe benign lesion, then also go for, if we are planning to observe, then go for biopsy, otherwise no need for biopsy. Clinical and pathological staging system provides a basis for standardized communication, comparison, prognostication. They are used to communicate risk for treatment, decision making, and clinical trials. And this most widely used staging system for RCC is the TNM staging by AGCC UICC. And compared to earlier version, now paracalcial invasion, that is termed as PT3A. And so for we will see, this is the TNM staging in which T1A is tumor less than or equal to 4 cm confined to kidney, T1B 4 to 7 cm confined to kidney, T2A for 7 to 10 cm confined to kidney, T2B more than 10 cm confined to kidney, and T3A is extended to renal veins, segmental veins, invades the perirenal fat, renal sinus fat, and pelvic calcium system, which is now added. T3B is extend into the IVC below diaphragm. T3C grossly extends into IVC above diaphragm or invades the wall of vena cava. And T4 is beyond gerotas, include continuous extension into the ipsilateral adrenal gland. N0 no nodes, N1 metastasis to regional nodes, M1 no distant mets. M1 is distant mets. Stage 1 is T1 N0 M0. Stage 2 T2 N0 M0. Stage 3 T3 NEN M0 or T1 T2 N1 M0. Stage 4 is T4 N0 NEN M0 and M1. Thank you.